Assalamu alaikum jami'an. Good afternoon, everybody. My name is Safwan Taha. I'm consultant metabolic and bariatric surgeon, and I'm the director of the Metabolic and Bariatric Surgery Center of Excellence in Mediclinic Airport Road Hospital. It's my pleasure to be part of this fantastic event. Thank you very much, Mr. Haddad, for the kind invitation. And well, I know he's been my literally brother for 2 decades, and he's been a leader of bariatric and metabolic surgery in the Middle East, not only in the Gulf. It's a very long list for me to really list. He's done almost everything, and I'm sure most of you know that. It's in the syllabus. So I'm just going to go ahead and invite Dr. Mohamed Hadad, consultant metabolic and general laparoscopic and metabolic bariatric surgeon, head of the Bariatric and Metabolic Surgery Center of Excellence in Healthpoint, the active medical director in Healthpoint. It's a very long list. Dr. Haddad is an international speaker and author and trainer. He's going to talk to us about the latest in metabolic and bariatric surgery. Abu Dhabi.
Thank you very much, Dr. Safwan, a friend and a brother and a colleague. Thank you for staying till this time. And I promise you my talk is not the best talk. The best talk is the last. So just hold on for Hassan Baydoun. He will give you new perspective for obesity. So I have no potential conflict of interest related to this talk. This is where I work, me and my colleague Sarah and many, Healthpoint, which is part of M42, which is the new name for Mubadala Health and G42. I just want to take a moment to thank the team that we work with. This picture, we took it last year, and unfortunately, it does not have all the people that work with us in the center. Lots of them are in the back, and everything I present is the hard work of these people. It's not only my hard work, it's our hard work. So thank you very much for everybody. So these are the outlines of my talk. What's new in bariatric surgery? I learned something from Carl yesterday. He said bariatric surgery has been consistent since 1967, which is great. It means we are standing the test of time. We are successful. That's why we are there. And that's why we will continue to be there. So the outline of my talk will be, we'll talk about the new IFSO terminology and classification, which is very important. Most of the people in the room are interested in research, so we'll talk about that. The new IFSO ASMBS guidelines. We'll talk about the anti-obesity medication. Lots of you in the room were members in IFSO trying to write recommendation and position statements on medication, which is a change. Surgeons, but writing guidelines and position statements on medications. We'll talk about that. Robotic surgery is getting more popular. We'll have a look on that. There is new novel techniques for magnetic compression anastomosis, gastrojejunal anastomosis. But the most striking thing is the change in the practice. And that's what we see right now. And then I will touch about what's happening with metabolic and bariatric surgery in 2023 and 2024. So this is the new terminology, and this is very important. This is from the IFSO position statements and from the obesity surgery. So if you are planning to submit any research, please use these terminologies. Lots of you, again, were in those task forces to change these terminologies. So the word morbid obesity should not be used anymore. We're using the term severe obesity. Comorbidities is changed to obesity complications. Less than ideal body weight or ideal weight loss, suboptimal initial response. Significant weight regain, late post-clinical deterioration, morbidly obese patients, we use patient with obesity, and we write it as P, W small, and O capital. So this is patient with obesity. Revisional surgery has been lots of confusion about revisional surgery. So revision is modification of the original procedure. Revision or conversion is changing the procedure to another one. Reversal is restoring the GI tract. So if you are submitting any article for obesity surgery, or if so, please use these terminologies, otherwise the paper will be returned. You have to correct these. So this is very important. This is one of the new changes. And this is the new classification. It's not new. We are removing the word morbid obesity. We are using the term severe obesity. And we used to use the word super obese, and super obese, and super obese, and quadruple super obese. It's not anymore. So now we call it severe obesity, class 1, class 2, class 3, class 4, class 5. Don't ask me what's when the BMI is 70. It will be class 7. Phil Shower is working on something, and I don't know if he will come up with something, because those patients are completely different from the BMI of 40. The surgeons among the group would know what does it mean when the BMI is 70 and 80. I borrowed this slide from Dr. Rubino, and I think at least I can point 3 or 4 members in the attendance working on this clinical obesity. They are keeping us on our toes, waiting for January to see what's the clinical obesity. It does make sense, because as you see in the picture, the boxer has no obesity, but those people has obesity. And we've been hearing over the last 2 days that some people has obesity but had no medical problems. They are completely healthy, and some people are really tired. So what's the clinical obesity? I will try to ask Nasreen. I don't know if she will answer me. She will not. We have to wait. 14. We have to wait for January. So basically, in January 14, there is a task force by the Lancet Commission. Iba is there. Iba will never tell me. Nasreen, I might. So there will be a new definition for obesity telling us how to deal with the problem, because the problem is bigger. This is how it used to look, how we treat obesity or patients with obesity. And thank God, this is how it looks right now. So medication is approaching, and we are very happy because this will offer our patients more options, specifically patients with severe obesity, class 1 and class 2. However, bariatric surgery continued to be more effective, but as usual, there is nothing without price. I love history, and probably those of you who attended lectures with me, so this is the first ever recorded bariatric procedure, if we want to call it bariatric procedure. So this has happened in the 10th century. This is a king of Leon. He was morbidly obese. He lost the throne. He was not able to ride a horse. So he was sent to his grandmother in Spain. She took him to a surgeon. And when we have a patient in the clinic, or when we see a patient, we cannot say that we cannot do anything for him. So the surgeon sutured his lips and put a straw for him and gave him something to drink, a mixture called Terrace. The Terrace has lots of opioid. He had nausea, so he lost weight. He went back. He regained the throne. Few years later, he regained the weight, and he died. This is the story of obesity. Then, again, I said I'm interested in history. So the term bariatric comes from basically a Greek word. If you divide it into 3 parts, bar is weight, and basically it's pertaining treatment for weight. And in 1978, one of the icons of bariatric surgery, Dr. Bockwald, changed the term into metabolic surgery. I've been asked many times, what do we call it, bariatric surgery or brain surgery or hypothalamic surgery? The term is metabolic or bariatric surgery. That's what we use. So it's metabolic/bariatric surgery. Basically, it's called metabolic because we are operating on a healthy organ, like the stomach or the intestine, and we want another results, which is diabetes and hypertension and weight. It's not unhealthy organ. The ASMBS and the IFSO came up with new guidelines for bariatric surgery after so many years, after more than 30 years of the NIH. And basically they said, we'll drop the BMI to 30 to 34.9 plus metabolic disease, or BMI is 35 with no medical problem. For Asian, of course, we know the criteria is a little bit different. Older population, they went to 70 years, and for adolescent, as you see it, 140 percentile or 120 plus obesity complication. In the Emirates of Abu Dhabi, we were one of the first people to have a standard of care, and I will stress on the word standard, because guidelines is you can follow it or you can't follow it, but standard of care, it means if you don't follow it, you are deviating from the standard. And this is so far our standard of care right now, what we practice, BMI 30 to 34 with poorly controlled type 2 diabetes. And we stressed in the standard type 2 diabetes is not said by a surgeon. It has to be by an endocrinologist, because this is their specialty. A surgeon cannot decide whether this is poorly controlled or not. And 35 to 40 with one medical problem, and 40 with no obesity complication. We made it to the consensus between the American Diabetes Association and the European Diabetes Association, but unfortunately we made it in the lower half. We hope that one day it will come up and it will be discussed with the patient. Unfortunately, till today, I see patients with poorly controlled type 2 diabetes with BMI of 40s and 50s, and they come, I say, the endocrinologist send you? They said, no, I came by my own. Which, I'm not saying send these patients to have surgery. I'm just saying discuss it with them. Give them the option. Tell them that you might have surgery, and tomorrow morning after the surgery, the day after surgery, your blood sugar, you have a chance in 15 years, you'll be off medications. Let him take that decision. This is an informed consent. Give him the options. Give him the alternatives. This is how it should be. And hopefully one day we will make it. The IDF, the same. They said it's safe, effective, and cost effective, and it should be considered when the BMI 35 and above. Unfortunately, we've been fighting to say it's a chronic disease, but we don't have a combined guidelines to manage obesity. 2 days ago, I was giving a talk in Dubai, and a question came, how do I treat the patient? I said, it depends on the stage, it depends on the class, it depends on the severity. But this is from experience. Where is the reference? There is no reference. And hopefully, one day we will have standard of care or management or recommendation or guidelines or a guide or a paper from WOF, from IFSO, from ASMBS, from EASO to tell us what to do with these patients, like the cardiologist or the endocrinologist, or like hypertension or thyroid disease. And one day, hopefully, we will reach there. The reason we don't have that, because it used to be a surgical disease, but thank God in the last 2 years, it's now medical and surgical disease at the same time. As I said, there is a change, there is a shift in the paradigm. Now we have surgeons trying to talk about medications. Sarah and Nisreen knows about the task force that was put by IFSO to try to write some position statement about the obesity management medications. Now there was a discussion whether we call it anti-obesity medication, we call it obesity medication, or obesity management medications. And it was 50-50 divided. 30 people in the room, they couldn't agree on. I was one of them. We couldn't agree on one, so they called it obesity management medications. The position statement will be released very soon. And basically, these are the highlights of it. It can be used before metabolic and bariatric surgery, especially with severe obesity class 4, class 5, and 6. It should be stopped before bariatric surgery. And those of you who are doing endoscopies, they see that even when patients, they fast for 20 hours, their stomach is still full. Because we know one of the side effects of GLP-1s is gastroparesis or delayed gastric emptying. So before surgery, if they are taking it daily, it should be stopped at least 2 days. If they are taking the weekly, it should be stopped 2 weeks before endoscopy and before bariatric surgery. You can say, if you look at the literature, it's totally mixed up. Some say yes and some say no. But what makes sense, right? And we all scope patients, and we saw how much the stomach is full, so it should be stopped. It can be augment or maintain weight loss. It does reduce the cardiovascular risk, but we need more research. And the position statement stressed that patients with obesity should have access to all modalities of treatment, not only surgery, not only medication, not only diabetic patients. Robotic surgery is getting more popular. However, I'm not a robotic surgeon. I'm not biased against robot. I just put in PubMed, I said robotic surgery, bariatric surgery, just give me from 23 to 24. And this is what I could found. These are the top articles that came. So the conclusion, it is safe after the learning curve. However, everybody agreed the cost is more. And we are in an era where we need to look at the cost. So I don't think we can add in the cost, but all the studies agreed that robotic surgery is more costly than laparoscopic, conventional laparoscopy. And they take more time because ducking the robot. Now people, when they say with experience you can duck the robot in a minute, I don't know how can you duck a robot in a minute. You can probably, I don't know. Just like when the anesthetist, he say, I can intubate a patient in 10 seconds. I don't know how they do that. Probably it can be done. I'm not saying, I'm not against it. But looking at the literatures, it's costly, it takes longer time. It is as safe as conventional laparoscopic surgery. It has a place in very difficult, complex revisional procedures. That's the conclusion from the literature. There are some novel techniques. So this is a publication from Michel Garnier. It's at the experimental level. So they are trying to find another way to do the anastomosis in gastric bypass. So basically, endoscopically, they put a magnet inside the stomach, and laparoscopically, they put a magnet, the other part of the magnet inside the intestine, and then try to put them together and just leave. And usually within 1 week, because of the pressure, there will be necrosis, and it will create an anastomosis. So they did this on swine, and they did it with 3 sizes, 4, 6, and 8. The 8 one stayed patent. Some of the 4 and 6 didn't stay patent. So the 8 is the one that should be stay. And usually this magnet should come through with the stool, but one of them stayed in the stomach. It's still at the experimental stage, but I know they started on human. So this was the animal study that was published. The most important change in bariatric surgery in 2024 is this slide. What we are dealing with today, we are dealing with more severe or multi-complex disease. Usually, the patients with a BMI of 35 and 40 and 45, all these patients now are electing to use the medications, and we get the 60s and the 70s and the 80s. So more complex disease, more severe disease. Those surgeons who keep saying that I'm interested in the low BMI, I don't think there is a place for them anymore. Older patients, personally or in our center, when we have a patient with above the age of 60 or 65, we think twice. But with the new evidence that these people, they do well and the quality of life improve, this has been pushed slowly to 70. And even in the new guideline, they said 70 should be taken, but 75 is okay. The older patient that we've operated on in our center is 75. But the patient did very well. But we took our time. We discussed that patient. We don't go without a green light from Sarah. We discuss these patients. We don't look at the number. We look at the real age. Sometimes we have a 60 years old who looks like 80, and sometimes we have an 80 years old who looks like a 60. So we look at the real function of that patient, their real life, and whether it's an informed consent or not informed consent. The 75-year-old that we've operated on, her daughter was a physician, which helped. So we brought the daughter, we told her about the risks, we told her the patient had multiple surgeries, abdominal surgeries, open surgeries, complicated surgeries. So we told her about the risk, and they did accept that risk. We did the surgery, and the patient now, almost 8 years after the surgery, off the diabetes medication. She's very happy in her quality of life. So older patient. Sicker patient. We used to say that the risk of anesthesia because of these patients. I remember my room was the punishment room for the anesthetist. Any anesthetist that does anything bad, they put him in the bariatric room because our patients are difficult. I remember one of the anesthetists told me one day, "Why all your patients are difficult?" I said, "Because they are morbidly obese. They have the disease." But now we are dealing with 60s and 70s and 80s and 200 kilogram and 250 and 300 kilogram. So these patients are sicker. And one more thing that's changing in the practice, and that's what we see. There's more balanced ratio between male and female. It used to be more females, now it's more balanced. Now we'd love to operate on women because their abdominal habitus is different. Men are much more difficult because of the omentum, because of the thickness of the abdominal wall, because of the hormonal, pear shape versus apple shape. But now we are seeing almost equal between males and females. More risky, more severe, higher anesthetics and surgical risk. Dr. Rubino was talking about a patient on home oxygen and barely maintaining an oxygenation of 85 with the home oxygen, who was refusing surgery, and the lung transplant team refused to do the surgery. But then the patient said, "Well, I don't have a life, just take the risk." They took the risk. The patient is off the lung transplant list. He doesn't need a lung transplant anymore. So we are taking much more. And of course, we are doing more revisions because those patients who had surgery before, they didn't respond, and now they come for second or third procedure. So I'll give you just a quick review of what do we know about the effect and the durability of bariatric surgery. We're all aware of the Swedish obese subject study. What's more interesting that we have lots of publications coming. This is the most cited study. This is the study that changed the history of bariatric surgery all over the years. And we have so many publications to tell us the good news. But again, there is nothing without price. So there is a little bit of dark side for it with the suicide, alcohol abuse, fractures, and anemia. The problem with the Swedish obese subject study that it was not non-randomized, it was prospective, and the follow-up was great because in Sweden nobody moves, so they have a follow-up of 99%, which is almost impossible to do anywhere in the world. So what do we have in the new? We are all aware of the Mangroni-Rubino study. We have the 10 years data, which showed the weight loss is significant with bariatric surgery, but more importantly is the hemoglobin A1C and the glycemic control, which is always in favor of bariatric surgery. More important from that same study, if you see the micro versus macrovascular changes, and what's interesting, only 5% of the surgical group have microvascular changes. And the reason behind that, because when we do the surgery, we put the disease in remission. We don't cure the disease. There is no cure. The cure is not to have the disease. So we put the disease in remission. More studies published in May 2024. Long-term study, 106 patients, very good follow-up. 80% of the patient had almost off medications with normal hemoglobin A1C. But again, it's not without side effect. Like everything in life, like the medications. And Going ahead with surgeries, this is the ARM study, which is basically the 4 randomized controlled trial that was done in the United States, Stampede, Crossroads, SLIM, and Triabetes. They pooled their data, 226 patients, all of them randomized controlled. The problem there is some of them had gastric banding, some of them sleeve, some of them Roux-en-Y gastric bypass, and I will not show you the weight loss because we know the weight loss will be in favor, but I will show you the hemoglobin A1C, and you see its intention to treat analysis. So if you see at 6 years, between 4 and 6, 25 cross already to the surgical group, and if you look at the hemoglobin A1C 12 years after the surgery, it's 8, and 40% of those are on GLP-1, while in the banding and sleeve is 7.3 and only 15% on GLP-1. And the benefit is shown with triglyceride, with cholesterol, HDL cholesterol also. So their conclusion, superior glycemic control in a randomized, multi-center controlled trial. OSA, we know, it's one of the benefits of bariatric surgery. This is 150 patients. 90% of them had resolved, and they don't use the CPAP 5 years after the surgery. How about liver? We already heard from Laith about, Dr. Laith yesterday, about the fatty liver disease or MUSCLE, and this is one of the really underrated problems or complications of obesity. And just to give you perspectives, one liver transplant cost an average between $750 to $1 million. With the $750, we can treat 150,000 patients with obesity. And number one cause of liver cirrhosis in women since 2022 is obesity. So if I save one liver transplant, if I save one patient from having liver transplant, I can treat 150,000 patients. So this is basically a randomized controlled trial. Again, open label, 1 sleeve versus bypass versus lifestyle, and they wanted to see biopsy-proven NASH. And the result were always in favor of the Roux-en-Y and gastric bypass and sleeve gastrectomy versus the lifestyle modification. So the calculated probability of NASH reduced by 3.4 times, 3.6 in Roux-en-Y and 3.67 in a sleeve gastrectomy. And I want to conclude with a very important study. As bariatric surgery has been linked with increased incidence of reflux, increased incidence of probably cancer, esophageal cancer and gastric cancer. And this is a large national database from France. It was published in 2023. They looked at 300,000 bariatric surgery procedures or patients versus 600,000 patients. And they were matched 1 to 2 on age, gender, comorbidity, and BMI, and a follow-up 5 to 6 years. And again, this is a national registry of France. So nobody can play with the data. And there were almost 330 cancers. Esophageal cancer in the metabolic and bariatric surgery group was 83 versus 254 in the control group. And the incidence, if you see per 100,000, this is how we calculate cancer, esophageal cancer. In the surgery group is around 5 versus 7 in the control group. And the hazard ratio is reduced to 0.76. So bariatric surgery is associated with decreased risk of esophageal and gastric cancer, according to this national reference from National Database of France. So, in conclusion, ladies and gentlemen, we have a new IFSO terminology. Please remember to use these words. Don't use the word morbid, just replace it with severe obesity. We have a new IFSO guidelines. Robotic surgery is getting more popular. Surgeons like it. Surgeons start talking about obesity medication, which is great because now we are thinking about the patient. We are not thinking about the surgery, and I'm very happy with that. There are some novel techniques. There are some AI models to predict the response. Some very preliminary studies from Poland about the functional MRI, trying to predict the response, an AI model to predict the response of bariatric surgery. There is a huge change in the paradigm. We are treating more old patients, sicker patients, multi-complex disease. But the bottom line, metabolic and bariatric surgery, still the most durable solution to treat patients with obesity. And Roux-en-Y gastric bypass continue to pass the test of time, specifically in patients with type 2 diabetes and gastroesophageal reflux disease. And thank you very much.
Thank you very much, Nabil, for yet another fascinating presentation, as always. So I'm going to start the questions here. I mean, it's been a really a wonderful day for me. I've learned a lot about the modalities, but the question stays wherever we went. So what's going to happen to bariatric surgery now with the advent of anti-obesity medications or obesity medications, whatever you call them, and probably there are 12 more in the pipeline, and bariatric surgery has been static, as everybody said, for like a quarter century. Still, the thing is, we still have evidence that shows that clearly. That's the only really long-lasting effect comes from bariatric surgery. So where do you see it in like 8, 10 years?
It will be there, but as I said in the slide, it will be for sicker patients, more complex patients, more severe patients. Very good question, excellent question. I was asked by one of my physician colleagues, he said, we found the treatment for H. pylori. I said, you find the treatment, this is similar to peptic ulcer disease? I said, where is the treatment? Where is the cure? Peptic ulcer disease, we don't do it anymore because they found the cure for the bacteria. But where is the cure for the obesity? We will be very naive to think that these medications will wipe out bariatric surgery because these medications are a treatment just like treatment for diabetes. There is a treatment for diabetes for 50 years, but diabetes didn't disappear. It will be there. And even when we give the medication, that's what I said, let it be an informed consent. If you tell the patient, I will control your blood sugar with GLP-1s, it's great, it's wonderful. But tell the patient he will be on it for life, and tell the patient I'm not stopping the disease. When I do the bariatric surgery, or when you do it, you put the disease in remission from that point. The patient will wake up in the morning with normal blood sugar and no anti-diabetes medications.
Well, thank you very much. Actually, this is the point I wanted you again to go back and stress, because just like Dr. Lohr very practically raised the point that can anybody really do that medication for life? It's not only the cost, not only the side effects, there's so many things. So, or shall you tell him? So I think probably, I will agree with you totally, actually, not probably, that the key to this is you give the patient the choices and an informed consent. Thank you very much for that.
Hello. Hi. A comment and a question. The comment is about exactly the thing which you said. I think we will always need, I mean, as an obesity physician, we will always need you and you will always need us. So that's the comment. And the question is about the nomenclature. Even if I want to avoid using morbid and all these things in my notes, if I click on ICD-10, and the diagnostic classification, they are still come as morbid obesity. And what is the leadership going to be doing about that?
Thank you very much. It's a very good point. But these changes happened just this year, the new terminology. So I'm sure it will take time. When ICD-11 probably will come, they will change it. But this is the notion between ASMBS, between European Association, between EASO and IFSO. And what we are trying in this, I mean, I'm very happy to see there are so many surgeons in the group now, because now we are treating the patients. We are not looking at, we used to, Dr. Osama, one of the most brilliant surgeons in Saudi, is nodding and agreeing with me. We used to go to meetings where we talk to each other. Bypass the roux limb and the biliary limb, and what do we do, and the pouch. Now, he is here, Dr. Safwan is here, many surgeons are in the group, and we are coming to these meetings. So that's how we look at it. This is a step forward to look at the patient the best interest of the patient, not the best interest of the surgeon and nor the physician. And what you said is absolutely right. We have to believe that the patient with obesity will need you, and will need me, and will need Sarah, and will need Nisreen, and Iba, and everybody in the room. We'll need the cardiologist, we'll need the gastroenterologist, we'll need the endocrinologist, and we'll need the surgeon. Everybody has a role.
Okay, so thank you very much.
Thank you. Thank you very much.
Everybody. A question? I'm sorry, I have the lights in my eyes.
Okay.
So Nawaf
Dagher
from Iraq. Yeah.
I have one comment. We spent 2 days trying to find a guideline, a comprehensive guidelines to cover the treatment of obesity. Actually, I'd rather to say we will never find it. Every patient should be treated as a separate individual. We have a lot of our patients, they are coming for weight loss not because they are obese. They are looking for other target. A lady looking for conception. She's not intending to lose her weight. She may find herself nice with this weight, but her gynecologist told her that lose weight and you will get pregnant. So these issues make every patient is a single individual entity, and we should treat them, everyone alone.
I totally agree. The guideline doesn't mean that we have to treat every single patient the same way. Every single patient is different, but we need a guidance.
Yeah, MDTs. Only MDTs.
Yes, yes, I agree with you. Thank you very much.
Thank you.